All right, everyone. Good morning. I am so excited. Each and every one of you are here today. If you don't mind opening up your chat box, change your settings to all panelists as well as attendees. And I am so excited to get started just in a few minutes. If you guys can hear me and see me, can you go ahead and put in yes into the chat box, please? Just want to do a quick little audio check here. All right, wonderful. We got a big class today. Excellent. And yes, please change your chat box setting to everyone so that we can all participate in the active recall questions today. Awesome. We have some people from Virginia, Georgia. Where's everybody else from? Go ahead and put it into the chat. Great. We're going to get started in just a little bit. We have people from Nigeria, Ecuador, some familiar faces here, which is great. Ahmed from Minnesota. Great. All right, just a couple more minutes. Sit tight. Make sure you have your coffee or tea right next to you, and we will get started soon. All right. Well, if you haven't already, why don't you go ahead and put into the chat box where you are logging in from. We have an international audience today. Over 200 people are joining this live stream. This is such a high yield webinar today, and I'm so excited you all are here. We have people from Ohio, Kansas, Indiana. Go ahead, keep them coming. I love this. We have people joining in on YouTube as well. Excellent. Well, thank you all for joining. I am so excited to get started today. We are going to be covering oncology in a systems-based approach. This is a very unique webinar because, as you probably know, throughout your organ system review, whether you're doing reproductive, cardiology, respiratory, you get a flavor of oncology in each and every system. And so today, what I'm going to do is I'm going to just integrate all of those systems together and have a focus on oncology. This is a unique webinar. And before I get started, I wanted to just go through a quick introduction. Now, for many of you who don't know me, my name is Rahul. I'm a current pediatric critical care fellow. And over the past 5 years, I've just been absolutely passionate about helping students just like you prepare for the USMLE exam. I am so excited you all are here. And for those of you who have been to my webinars before, welcome back. Here's my contact information, and please connect with me on social media. We're also going to be having a live Q&A at the end of the webinar, so definitely stay tuned. If this is the first time you have heard of HyGuru, I wanted to just spend a few minutes going through what makes HyGuru so unique, because I know that there are so many resources already out there. Well, when I started this project about 7 years ago, I really wanted to find an evidence-based approach to USMLE preparation. And so I realized that a solid USMLE program is going to be focused on active recall that definitely transcends just Anki, integrating concepts together, and focusing on test-taking strategy, which is key because it's not just about knowing the content for your exam, but it is also about the application of the content. And I want to deliver the application of the content in a very literal way, in a very engaging and energetic way. And you guys will see that today. So when I prepare students one-on-one or in medical schools for the USMLE, I focus on three things. I focus on the content, integrating the contents across domains. I focus on test-taking strategies because I want to make sure that you can apply the knowledge to the question and have a systematic approach so that on test day, you are going to be feeling very well prepared. As many of you are studying right on your own, well, guess what? I 110% feel like it's a psychological battle as well. And so I work on optimal mindset and peak performance. And I also make sure that you are productive day to day with a solid study plan. Most importantly, I have absolutely been humbled to have HyGuru just be a community. We are now a global community. And more than anything, I have been humbled to teach at top medical schools my own passion, which is USMLE preparation. So what inspired me to create this webinar was actually a simple post on Reddit that was now about 6 months ago. And it covered the most important content points which come up on every single NBME. And I used this outline and also added my own gusto to these lectures and came up with a series of very, very high yield lectures. And ladies and gentlemen, we have literally over the past 3-4 months covered each and every organ system. And today we're going to cover the last one, and that's going to be oncology. I am so excited that you are here today. And for many of you, like you all have been here since the beginning, and I'm so humbled by that. If you have missed my old reviews, well, guess what? They're on YouTube. I made a playlist, the NBME Top Concepts playlist, and you will be able to go through each one. They're about an hour and 15 minutes on single speed. What I also want to let you know is that I have 2 awesome free resources right on my website, hyguru.com. One of them is a first aid outline. Now, this first aid outline is extremely unique because this first aid outline actually has the biochemical pathways and microbiological agents that you need to know divided up by organ system. So why that's so important is because when you're going through endocrinology and you're going through the pathoma and the pharmacology related to endocrinology, you'll be able to tie in biochemical pathways like glycogen metabolism, gluconeogenesis, glycolysis, etc. I also have a very free Goyan style course, and those are my NBME Top Concepts videos, just chopped up into small, high definition videos so that you can track your progress. There are a bunch of practice questions that go along with these videos, and it's absolutely completely free. And as I've grown this library, you have essentially a comprehensive, curated, high yield course for your preparation. And this course is so important because if you are just gearing up for the exam, if you're in your school modules and you need to review one organ system, maybe you're taking the CBSE, I highly, highly, highly recommend you watch these videos. over 1,500 people so far have signed up for this absolutely free course. All you have to do is put in your email and you get access to all of the videos. All right. So without further ado, I appreciate each and every one of you for sticking with me through this introduction. I want to ask you the most important question, and that is, are you all ready to get started? And if so, go ahead and put yes into the chat box. All right, Chitra's ready. Rahul, Miriam, wow. Yui, Sam, well, thank you all for joining. And one disclaimer before we all get started. I ask for 1 hour and 15 minutes of your time today. Please cut out distractions. Make sure that you are closing all of those redundant tabs and just focus with me, because this is a active recall review. I've spent over 12 hours just putting this review together, and I promise you it is going to be covering the most salient points you need to know for your USMLE exam. This is going to truly bump up your score. Let's go ahead and get started. The Bollywood in me is like dancing right now, and I'm excited to share that energy with you. Here we go. So NBME top concept for oncology. Let's go ahead and go through the outline. So essentially what I did was I went through each and every organ system and I isolated the high yield tumors from each of the organ systems. So in cardiology, we're going to be talking about the difference between a myxoma and a rhabdomyoma. In endocrine, we're going to be talking about thyroid carcinomas. In GI, we're going to be talking about colon and esophageal cancer. For hematology oncology, I'm going to be specifically going through non-Hodgkin's lymphoma and also covering vascular skin tumors. These show up a lot on your NBME. For neurology, I'm going to be covering brain tumors. For renal, I'll be covering 2 sets of cancers, renal cell carcinoma and nephroblastoma, also known as Wilms tumor. And then we're going to end by talking about breast cancer related to reproductive. All right. So going through this a little bit more, let's go ahead and go through our first topic, and that is going to be the difference between atrial myxoma versus a rhabdomyoma. Let's go ahead and get started with the question. A high school athlete presents with a 2-week history of shortness of breath on exertion. He has dizziness and vital signs showing bradycardia with normal blood pressures. A diastolic murmur is heard that abruptly stops mid-diastole. Exam or echo shows a pedunculated heterogeneous mass in the left atrium. Which of the following accurately describes this diagnosis? A, myxoma, B, teratoma, C, rhabdomyosarcoma, D, thrombus, E, lipoma, F, astrocytoma. Why don't you go ahead and get warmed up here and go ahead and put your answer into the chat box. All right, we have a lot of people who are saying A, and if you said A, you are absolutely correct. Let's go ahead and go through the explanation. Remember that when you're talking about an atrial myxoma, it is going to be a pedunculated mass, which means it's within the left atrium. During diastole, as the blood is going from the atria to the ventricle, you are going to hear the plop of this tumor. And what that means is that you are going to have the tumor get into the orifice of the mitral valve, and that is going to obstruct what? Preload. You're absolutely correct. Now, what about a left atrial thrombus? Guys, make sure you integrate that for a patient who has atrial fibrillation on your USMLE exam, because that relates to Virchow's triad. Remember, stasis, endothelial injury, and hypercoagulability is the triad for how we make a clot, and AFib relates to stasis. So if we do a compare and contrast of these primary cardiac tumors, a cardiac myxoma, also known as an atrial myxoma, can be sessile, which means flat, or pedunculated. And it has this ball valve type of pathophysiology in which the tumor plops into the orifice of the mitral valve. And that primarily is going to be heard in diastole. Now, these patients are going to have low levels of inflammation in your test question. So watch for fever, fatigue, malaise, and anemia. And usually this anemia is going to be a normocytic anemia representing anemia of chronic disease. Now, going into this ball valve effect, remember that if you obstruct preload, you are going to not be able to have good left ventricular end diastolic volume. And subsequently, during systole, that's going to cause a lack of cerebral blood flow. And so these patients frequently are going to present with syncope. Now, let's compare and contrast with rhabdomyoma. Now, rhabdomyomas are also going to be tumors that are found primarily in the atria. They are related to tuberous sclerosis. And I think that that's exceedingly high yield. Remember, tuberous sclerosis has gene mutations on the 9th and 16th chromosome. Tuberous sclerosis is going to be associated with hamartomatous growths throughout the body, and cardiac rhabdomyomas are actually these hamartomatous growth, which is basically disorganized cardiac tissue. These patients actually present with a holosystolic murmur related to mitral regurgitation, and they can say that there's a mass in the apex or in the atria. Now, when you think about oncological lesions to the heart, remember that metastasis is the most common. And I want you to recognize that cancers such as breast cancer can metastasize to the pericardium, cause you to have some element of inflammation at the pericardium, and these patients can have pericardial effusions. And so when you do a pericardiocentesis and take out all of that fluid, you may see tumor cells of the origin tumor. So oncological lesions to the heart, always think about metastasis prior to these primary cardiac tumors. So I love to actually integrate different syndromes for your USMLE. And because we talked about cardiac rhabdomyomas, I do want to talk about tuberous sclerosis. So tuberous sclerosis has multi-system involvement. When you think about the CNS, you're going to be thinking about subependymal giant cell astrocytomas as the oncological lesion in the brain. Cardiac related, we talked about cardiac rhabdomyomas. When we're thinking about renal tumors, this one is high yield, and that is renal angiomyolipomas. Remember, they have blood vessel, muscle, and fat. And this is going to be presenting on your USMLE as a renal mass. What are some other associations with tuberous sclerosis? Well, we talked about hamartomas. Remember that these patients can be prone to seizures. They can have skin lesions. And the one that gives it away on the USMLE are these ash leaf spots. So ash leaf spots are going to be hypopigmented patches on your skin. And don't get that confused with neurofibromatosis and cafe au lait spots. Remember, cafe au lait spots are going to be hyperpigmented. I did want to show you this histology slide regarding angiomyolipomas. As you know, here is the muscle. There are blood vessels that are going to be interspersed throughout this picture, and then fat. So that's why angiomyolipomas can be very high yield. What I do want you to recognize is that whenever you have many systems involved within a test question, for example, seizures, a heart abnormality, a kidney abnormality, anytime you have multi-system involvement, always think about a genetic syndrome or a systemic condition. That will really allow for you to cue in your knowledge and focus on the correct answer choice then. All right, so we are done with cardiology, not too much there. But now we will switch gears and talk about thyroid carcinoma. So how I'm going to organize thyroid carcinoma for you is essentially going back to basic histology. Remember that the thyroid is going to be in the neck, and thyroid cancers actually are going to present as a neck mass or a goiter. And remember that this, as it grows, can have local compression. And that's why patients can even present with stridor because of the tracheal compression. Now, when you look at the histology of the normal thyroid, you notice that there's colloid, there's going to be follicles, and there's going to be these parafollicular cells as well. So the colloid is going to be number one. The whole follicle is this area right here. And then you have the parafollicular cells that are going to be surrounding your colloid and the overall follicle. And each of these elements can actually end up having some tie to cancer. And so that's what we're going to focus on next. What I'm going to be doing in this table is essentially breaking down the risk factors that you need to look for in your exam questions, and then cover 3 of the most common types of cancers related to the normal histology that we just went through: follicular thyroid cancer, papillary thyroid cancer, and medullary thyroid cancer. So when you're thinking about thyroid cancer, you got to clue in on these risk factors. And those are going to be neck radiation, especially related to papillary carcinoma of the thyroid. They usually are going to present as a neck mass. We talked about the stridor, but remember, anytime you see fixed, non-tender, or nodular with actually a variegated appearance, you want to think about cancer of the thyroid. You also are going to see it in what kind of syndrome? That is MEN2 syndrome. And we're going to be covering this at the end of the slide. But remember, MEN2 syndrome is going to be related to the RET oncogene mutation as well as medullary cancer of the thyroid. So follicular cancer, what you have to know for your USMLE is that it actually presents with vascular invasion. So it's a thyroid mass with distal metastasis. And I always think of the mnemonic follicular, follicular, vascular, follicular, follicular, vascular. And so that tells me that follicular carcinoma invades the blood vessels very readily. Many cancers that we will talk about today are going to have this P53 mutation, but there is a specific mutation with the PAX8 and PPAR gamma for follicular carcinoma that can sometimes show up on exams. Papillary cancer is going to have a key histological characteristic, and that is going to be these orphan Annie nuclei. Now, what do these orphan Annie nuclei actually represent? Well, they actually represent sparse chromatin within the nuclei itself, and that's why the nuclei end up appearing empty. Now, unlike follicular, which is vascular invasion, papillary has more of a lymphatic spread. Lastly, we're going to be talking about medullary carcinoma. And medullary carcinoma, very high yield for you to know, is derived from the parafollicular C cells of the thyroid. Remember, going back to normal histology, parafollicular cells are going to be surrounding the colloid, and those parafollicular C cells are actually going to be secreting calcitonin. Now, medullary carcinoma is the one that is associated with the MEN2 syndromes. And remember that MEN2A and 2B both have an association with medullary carcinoma of the thyroid. MEN2A is going to be associated with issues regarding the parathyroid gland, as well as pheochromocytomas. Whereas MEN2B is going to have oral gangliomas, which are neuronal tumors that you'll see in the oral pharynx, and bilateral pheochromocytomas. Remember that MEN2B is also going to have that marfanoid habitus. And if they ask you what is the oncological gene that is associated with both of these, that's going to be the RET oncogene. Now, what's also important for you to know is that if you see a thyroid cancer that has Congo red staining positivity or apple green birefringence, it's most likely going to be medullary carcinoma of the thyroid because it has a relation to amyloid, which is basically misfolded protein in the extracellular matrix. Now, what I wanted to also integrate here are psammoma bodies. And why is that? Well, papillary carcinoma of the thyroid also is going to have these laminated concentric spherules with dystrophic calcification. And that is going to be your clue in for psammoma bodies. So many papillary cancers are going to have psammoma bodies. So I think of my finger and I whirl that around and I add some calcification. So I know papillary, meaning finger, papillary cancers are going to have associations with psammoma bodies. So you have papillary carcinoma of the thyroid, you have serous papillary cystadenylcarcinoma of the ovary, which is a surface epithelial tumor of the ovary. You're going to have serous papillary uterine cancer, and you're going to have the two M's, which are meningioma and mesothelioma. Meningioma is going to be an exophytic mass that we're going to be covering later on in this review. And mesothelioma, remember that that is going to have those pleural plaques on your CT, and there's going to be an association with asbestosis. And so this is going to be a great example of a psammoma body. And why we got into this mess, that was the integration with papillary carcinoma of the thyroid. All right, time for an application question. Go ahead and get your chat box up. A 50-year-old male has a lump in his neck. His exam is notable for a mass in the right thyroid lobe. Fine needle aspiration reveals thyroid carcinoma. He undergoes thyroid resection. 3 days postoperatively, he is found to be, quote, whispering in a raspy voice. Which of the following complications likely occurred in this patient? A, injury to the accessory nerve, B, injury to a branch of the vagus, C, injury to the phrenic nerve, or D, injury to the hypoglossal nerve. What do you think here? Excellent. And I want everybody to participate. If you said B, injury to the vagus nerve, that is the correct answer. Remember that the key association is the recurrent laryngeal nerve, but the recurrent laryngeal nerve is going to be a branch of the vagus, and that is extremely high yield for you to know. Now, remember that when you're talking about the diagnostic management of many of these thyroid masses, you are going to be doing a fine needle aspiration, very high yield for you to know. And obviously, if it's going to be a malignant cancer, you're going to do resection, and that can cause you to have destruction or injury to a nerve as well as an artery. And we're going to go into that. Now, I love you guys so much. And that's why I'm going to integrate a little bit of embryology here, because what we're going to be going through is the pharyngeal arch integration with the recurrent laryngeal nerve. Now, remember that the recurrent laryngeal nerve is going to be derived from pharyngeal arch 6. And pharyngeal arch 6 not only gives the recurrent laryngeal nerve, which is a branch of the vagus, but it also is going to give rise to arterial structures, which are going to be the pulmonary artery as well as the PDA. And the way that I remember that is I take the 6 and I turn them into lungs. That looks like lungs. So pulmonary artery on the right, and then the PDA, because remember, the lungs and the heart are going to be connected via the PDA. Now, what muscle is going to be innervated by derivatives of pharyngeal arch 6? Well, those are going to be all the muscles of the larynx. And that totally makes sense, right? Because if you have recurrent laryngeal damage, you're going to have hoarseness, and your larynx is responsible for your vocal cord movement. Now, there's one muscle, the cricothyroid muscle, that is actually not going to be arch number 6. That is going to be arch number 4, and that's the superior laryngeal nerve. That typically does a lot of your pharyngeal constrictors, but also it does cricothyroid. And that's high yield for you to know because it's an exception. And then finally, I do want you to understand the clinical correlate, which is going to be hoarseness. Now, as we talked about the nerve that could be damaged with thyroid resection, I do want you to integrate the artery that could be damaged, and that is the inferior thyroid artery. It runs in close proximity to the recurrent laryngeal nerve. And remember that the inferior thyroid artery is a branch of the thyrocervical trunk, and that actually comes off of the aorta. All right, moving on, we are going to be talking about colonic carcinoma. But before I keep moving on, are you guys enjoying this review, and are you guys learning? Go ahead and type in yes into the chat box. I want to make sure you guys are all focused. Excellent. Thanks so much, guys. Let's go ahead and talk about colonic carcinoma. A lot of good pathophysiology coming at you. So when I think about the big picture related to colon cancer, I always want to integrate what makes cancer from just that common polyp that you may see on a colonoscopy. Now, if the polyp is going to have a large size, well, maybe you're going to say, we might be going towards colon cancer. If there is a sessile or flat growth rather than a pedunculated, which means that there's a thin stalk, if there's a more flat growth, you're like, ooh, that's going to be a polyp that is more likely going to progress to cancer. And then finally, from a histological standpoint, you're going to be thinking about the villous histology. And many of you know that mnemonic, that the villous histology is the most villainous. But as you can see here, there is going to be a lot of nuclear pleomorphism. So the nuclei don't look normal. There's going to be many atypical mitoses, and there's going to be high N to C ratio. Now, whenever you see this, you should always think of cancer for your USMLE. I'm all about creating general principles. And so anytime you see issues with the nucleus, abnormal mitoses, and increased N to C ratio, you really want to think of cancer. And colon cancer is a great example, or when you see a polyp that has these features, you need to integrate colon cancer and this specific sequence that we're going to be going through. So I'm going to now cover the adenocarcinoma sequence. And there are many gene mutations that are associated with the adenocarcinoma sequence, and these are frequently tested on the USMLE. So let's just start with normal colon. When you have normal colon, that's all fine and dandy. But then when you get a mutation in the APC gene, which is a tumor suppressor, you can actually have increased risk for developing polyps. So mutations in APC, which is a tumor suppressor, remember it needs 2 hits, that increases your risk of polyp formation. Now, subsequently, you can acquire a KRAS mutation. And remember, a KRAS mutation is actually an oncogene mutation. And that actually is going to give you the polyp itself. All right, so now we talked about, wow, we have a polyp. Watch for the size, watch for the histology, et cetera. Now, if that polyp undergoes an increase in cyclooxygenase activity or a loss of P53. Remember, that's that cellular checkpoint. If you lose P53, cells are not going to undergo apoptosis. And guess what? You're going to end up progressing to carcinoma. So this is the adenoma carcinoma sequence. And remember, it starts with APC, then KRAS, and then P53. You can remember AK53 as your mnemonic. So let's go a little bit deeper into this. APC is found on what chromosome? That is going to be chromosome 5. The 2 hits, because it is a tumor suppressor, 1 hit is what we call acquired. It's a somatic mutation. And another hit is going to be from your parents. It's a germline mutation. Now remember, oncogenes, such as KRAS, they only require 1 hit. And KRAS is going to tell the GTP and the cell cycle to just keep proliferating and proliferating. Now, finally, remember that this increase in cyclooxygenase activity actually is one of the mediators which causes you to have cancer. And so there is a small little correlation here, is that there may be a theoretical benefit of having aspirin reducing the progression of this sequence, because aspirin irreversibly inhibits via acetylation cyclooxygenase. And remember, that goes back to your arachidonic acid pathway. So let's go ahead and apply some of these concepts right here. A 60-year-old male presents with fatigue and passing out. He is noted to have dark stools, and his wife states that he has become increasingly thin over the past few months. He undergoes stool testing, which is positive for heme. Further workup reveals adenocarcinoma of the colon. Which of the following gene mutations is likely responsible for transformation of a colonic adenoma to an adenocarcinoma? What do you think is going to be the answer here? A, increase in NMYC, B, increase in CMYC, C, decrease in cyclooxygenase, or D, decrease in P53? And you're absolutely correct. You're talking about a decrease in P53. Now, ladies and gentlemen, I do want to go into a little bit of an integration, and that is, how do I think about cancer? I posted this on my Instagram yesterday, and I wanted you all to recognize that cancer comes from either too much proliferation or a lack of cells dying. And so when you knock out P53, you get a lack of apoptosis, and that is what's going to give rise to neoplasia. Now, I did want to really integrate some key colonic conditions. And these are conditions that are going to have an association with both polyps and even sometimes colonic carcinoma. So say that you have a patient on your vignette that has thousands of polyps on colonoscopy and very early onset of colorectal carcinoma. Now, the disease here is known as familial adenomatous polyposis. FAP is going to be a mutation in APC. That's my mnemonic, FAP, APC. These patients actually end up getting prophylactic colectomies because they are almost 100% going to actually progress to cancer. Now, say that you have a child who is going to have a solitary rectal polyp that ends up bleeding. Well, you're going to be thinking here of juvenile polyposis. Now, with juvenile polyposis, this is going to be hamartomatous growth on your microscopic pathology. And if you have multiple juvenile polyps, well, you're going to have an increased risk for cancer. Now, what about this? Dark lips and hands and hamartomatous polyps. This one is very high yield, and that's going to be Peutz-Jeghers syndrome. Now, Peutz-Jeghers syndrome is going to have mucosal changes and colonic polyps. And I think of the famous liquor, Jaeger, right? Jaeger is a dark liquor color. And so I think of, Jaeger is going to have this dark color on the mouth, and you're going to have colonic cancers with that. Now, you are going to have, with Peutz-Jeghers syndrome, increased incidence of colon, breast, as well as uterine cancer. And that's high yield for you to know. Now, what if you have colonic polyps and a bone mass? Well, that's going to be associated with Gardner syndrome. So think about you using your bones to actually garden things. So colon polyps and bone mass. That's going to be Gardner syndrome. And that's usually going to be associated with osteomas of the skull as well as fibromatosis. What about colonic polyps and CNS tumors? Well, here you're going to be thinking of Turcot syndrome. So think about you wearing a turban. So colonic polyps, Turcot syndrome, you're going to have CNS tumors, and those CNS tumors are going to be of glial origin or even medulloblastomas. So again, these syndromes are high yield because they have multi-system involvement. They have associations with polyps. These polyps can actually undergo cancerous transformation. All right, so really talking now about colonic carcinoma. Remember that colonic carcinoma is one of the most common cancer, the third most common cancer in terms of incidence as well as death. And this typically presents as fatigue and a microcytic anemia in a 60 to 70-year-old patient. Now, there are two mechanisms by which you can get colonic carcinoma. We already covered the adenoma carcinoma sequence, which comprises the overall majority of colonic carcinomas. Now, remember that these carcinomas from the adenoma carcinoma sequence are usually going to be left-sided in the colon. And when they are left-sided, i.e. towards the descending colon here, you are going to have the stool caliber change. And so you can get this pencil-thin stool with blood, and we typically call this narrowing a napkin ring lesion. Now, there's another type of pathophysiological process that can give you colonic cancer, and that is this microinstability sequence. Now, before I go into this pathophysiologic sequence, let me just explain to you what is a microsatellite. Now, a microsatellite is a repeating sequence of non-coding DNA that replicate with cell division. So it kind of comes on for the ride every time the cell is going to divide. And so there is a very unique pathology that you have to know for your USMLE called hereditary non-polyposis colonic carcinoma. Remember, non-polyposis means that it arises de novo. There is no precursor polyp lesion. That's a little different than what we were talking about in the last 5 minutes. And so this actually is a mutation in the mismatch repair enzyme. That's an important association with HNPCC, also known as Lynch syndrome. And so whenever you have a mutation of that mismatch repair enzyme, you actually don't have microsatellite stability, you have microsatellite instability. And not only can you get colonic carcinoma with that, but you can get ovarian as well as endometrial cancer. And so what's important for us to recognize is that these cancers actually are going to be more right-sided, and they can present with iron deficiency anemia. So what I like to say when I'm answering questions is that any unexplained microcytic anemia in a middle-aged patient that has plus or minus constitutional symptoms, think colonic carcinoma until proven otherwise. All right, moving forward with colonic carcinoma. Where is the most common site for metastasis? Well, typically we're going to be thinking about the liver. And why is that really high yield? Well, because the colon drains into the liver via the portal venous system. So if you have a cancer in the colon, you can then drain that into the liver. And how do I recognize metastasis on the USMLE? Well, anytime I see a scan or a gross pathology that has multifocal lesions, I worry about metastasis. Let's go through this very high yield vignette. A patient presents with fever and new onset murmur. Guys, anytime I see this, I think of endocarditis. His blood culture grows strep bovis, also known as strep galliticus. What is the next best step in management? And so this is going to be endocarditis that has this particular bug that is associated with colonic carcinoma. And so a next best step in management is going to be colonoscopy. Again, this is more of an applied way to ask these questions. Remember that bovis is going to be a gram-positive cocci chains that grows well in bile and not salt. And so what is very high yield for you all to recognize is that I could have easily just plugged in this description right here, and that would have made this question a little bit harder or a little bit more layered. Let's go through this question. A 40-year-old male is seen in clinic for health maintenance. His brother had colon cancer at age 50. Should the patient get colonoscopy? Go ahead and type in yes or no within the chat box. Should this patient get a colonoscopy? And if you said yes, you're absolutely correct. So remember, we typically start colon cancer screening at age 50. However, if you have a first degree relative, in this question, it was the brother, you start screening at age 40 or 10 years prior to presentation, whichever one comes first. The patient is now diagnosed with colonic carcinoma. What tumor marker may be helpful to track the progression? And that is going to be CEA. Now, CEA, not really good for diagnosis because it can be seen in, for example, COPD or pancreatitis, but it is helpful if you are going to use this tumor marker and trend with your therapeutics. All right, moving forward with our review and GI oncological lesions, we're now going to be talking about esophageal carcinoma. Now, esophageal carcinoma, let's break it down. When we first think about esophageal carcinoma, we need to look at the risk factors that are going to be present in exam questions. And that is going to depend on whether you're talking about a squamous cell carcinoma or an adenocarcinoma of the esophagus. Now, anytime I see squamous cells, not only in the esophagus, but throughout the body, I always say the word chronic irritation. And chronic irritation is actually so important for you to recognize because essentially, whenever you have chronic irritation, that's a cellular stress, and that stress can lead to a hyperplasia or a metaplasia, and either of those pathways can go down the dysplasia and carcinoma sequence, and we're going to cover that soon. Remember, adenocarcinoma, especially of the esophagus, you're going to relate to things like obesity and GERD. Now, the USMLE presentation for esophageal carcinoma is going to be primarily progressive dysphagia. Now, what does progressive dysphagia mean? They will put in the vignette that, the patient had issues first with solids because the patient was trying to swallow, and that mass within the esophagus kind of caused them to have an issue with getting that solid down into the stomach. But then as the mass grows, then it progresses to liquids. Now, these patients are going to have constitutional symptoms, especially weight loss. And remember that esophageal cancer is going to have early metastasis. And why is that? Because the esophagus itself has a very thin mucosa, and you can actually metastasize to the mediastinal lymph nodes, depending on where the esophageal cancer arises. Now, we talked a lot about GERD, and one thing that I do want to integrate, it's in my GI review as well, is this concept of Barrett's esophagus. Now, whenever you have chronic GERD, the stomach tissue ends up going up into the lower portion of the esophagus, right at the squamo-columnar junction. And chronic GERD ends up being a stress that ends up leading to metaplasia, which is basically normal tissue getting overcome by normal tissue. Now, metaplasia, very high yield for you to know, is going to be at the lower end or the lower portion of the esophagus. And that lower distal 1/3 of the esophagus, if it undergoes metaplasia for a long period of time, it can progress to dysplasia and then finally carcinoma. So remember, Barrett's esophagus is going to be a precursor lesion. Now, the interesting thing about metaplasia, and this is in my chapters 1 through 3 of Pathoma Review, the key for metaplasia is that if you actually get rid of the stress, you will have less of a chance, i.e. there may be reversibility in the change, and you won't be able to go down the dysplasia carcinoma sequence. So this is just talking about adenocarcinomas and squamous cell carcinomas in general. Remember that adenocarcinoma, you're going to be thinking of Barrett's esophagus. If you're thinking about the actual reproductive tract, endometrial hyperplasia, you can progress to adenocarcinoma of the uterus. H. pylori can lead you to adenocarcinoma, and DES exposure in utero can lead you down vaginal clear cell adenocarcinoma. Now, what's important is that adenocarcinoma usually arises for columnar epithelia with goblet cells. Now, squamous cell carcinoma, we talked about chronic irritation, and this is high yield. You've got to be thinking about things like achalasia, which has that bird's beak appearance. Remember, it's not progressive dysphagia. It's going to be syn dysphagia, and that's because you have high lower esophageal sphincter tone and the fact that you do not have good peristalsis through the esophagus. You're going to be thinking about smoking as well as alcohol consumption because those are irritants. And you're going to also think of squamous cell carcinoma of the skin related to actinic keratosis, which is in a sun exposed distribution. Remember, sun can be a chronic irritated lesion as well. All right, let's go ahead and apply some of these concepts. A 6-year-old male with history of hypertension and dyslipidemia presents with chest pain. He also has difficulty swallowing, dysphagia. He states that his chest pain is worse while lying down. There is no relation to activity, which basically means, guys, that there's no relation to any anginal type symptoms. This is primarily the GI tract. Chest X-ray and abdominal X-ray reveal a, quote, heterogeneous air-filled collection behind the retrocardiac border on the left side. So it's right here. What is the likely pathophysiology behind the diagnosis? A, laxity of the diaphragmatic lower esophageal region. B, congenital abnormality of the diaphragm. C, acute trauma leading to colonic contents in the thorax. Or D, lack of abdominal malrotation. And if you think that this is a hiatal hernia in which the stomach is going into the esophageal region, you're absolutely correct. And remember, hiatal hernias can cause you to have GERD as well as develop adenocarcinoma of the esophagus. So when we think of your esophageal carcinoma, you want to be thinking of the presentation, and that is this progressive dysphagia with weight loss and hematemesis. Now, when you think about the two types of cancer, we already went through it: adenocarcinoma, with your glands proliferate, and squamous cell carcinoma, where your squamous cells proliferate. Now, adenocarcinoma usually is going to be at the lower 1/3 of the esophagus, and adenocarcinoma of the esophagus usually is going to metastasize to the gastric or celiac nodes because it's right next to the stomach. This typically is going to arise from longstanding GERD, i.e. Barrett's metaplasia. Squamous cell carcinoma of the esophagus is usually going to be in the upper 1/3 and in the middle esophagus. This is typically going to actually metastasize to the cervical nodes because it's more upper, as well as the mediastinal or tracheobronchial nodes, because again, middle is right in that mediastinal region. These patients can have shortness of breath and hoarseness as presentation because you're going to have some element of airway narrowing, and the risk factors we already talked about are irritation. And one risk factor is, like, for example, longstanding achalasia, or even if you're talking about a patient who is drinking hot tea for a long period of time, they can actually have squamous cell carcinoma of the esophagus. All right, so that is going to be our GI cancers. Let's now go into the oncological lesions, specifically non-Hodgkin's lymphoma. So when we think about lymphomas on the USMLE, we are going to now compare and contrast Hodgkin's lymphoma with non-Hodgkin's lymphoma. Now, Hodgkin's lymphoma has a bimodal distribution. Typically on your exam, it's either going to be a younger patient or an older adult, and it has these classic B symptoms: fevers, chills, night sweats. Now, remember that there is a contiguous nodal involvement with Hodgkin's lymphoma, and these tumor markers and stains are really, really important. Many of Hodgkin's lymphomas are going to be EBV positive. They are going to have a stain that's positive for CD15 and CD30. Remember, 15 times 2 is 30. And you do need to recognize these owl's eye nuclei, which represent essentially Reed-Sternberg cells. And those are the classic pathognomonic findings for Hodgkin's lymphoma. Now, Hodgkin's lymphoma also is associated with increased IL-5. And remember, IL-5 actually is going to recruit eosinophils. There's a specific subtype of Hodgkin's lymphoma that frequently comes up, and that is a nodular sclerosing subtype. Now, this is going to be on your exam as a woman with a neck or clavicular mass, and there's going to be extensive collagen banding, i.e. sclerosis, on biopsy, and this actually confers a good prognosis. Non-Hodgkin's lymphoma has B symptoms, but not as much as Hodgkin's lymphoma. There is non-contiguous nodal involvement, so they're not in a lymphatic distribution. It's associated primarily with HIV or immunocompromised states, and there are going to be some subtypes, and these subtypes you definitely have to know. We're going to go into them in just a little bit. So when we think about non-Hodgkin's lymphoma, typically this is going to present with some element of B symptoms and a fixed lymph node. And there could be associations with EBV, HIV, as well as HTLV4. Now, remember that non-Hodgkin's lymphoma can actually arise from B cell or T cell lineage, and follow the colors with me. Remember that a lymph node is going to be comprised of B cells and T cells. So it makes sense that a lymphoma is going to have derivations from either a B cell or a T cell. Now, what are your B cell derivations? Well, you're going to be thinking about Burkitt's lymphoma, diffuse large B cell lymphoma, follicular lymphoma, mantle cell lymphoma, and marginal cell lymphoma. You also have this unique one, which is known as primary CNS lymphoma. Now, the T cell lineages are also going to be high yield, and those are going to be adult T cell lymphoma, which is going to be related to HTLV infections, as well as this mycosis fungioides. Now, mycosis fungioides, very characteristic. It is going to be a cutaneous T cell lymphoma under the umbrella term of non-Hodgkin's lymphoma. So watch for that skin rash and malignant T cells. Before we go into the breakdown of specifically the B cell non-Hodgkin's lymphoma, I do want to create a general concept for you. And that is that a lot of these B cell derived tumors are going to have high yield translocations that you need to know. And a lot of the translocations that you will see arise from chromosome 14. And when we understand the genetic translocation, we have to recognize that chromosome 14 actually is going to encode for immunoglobulin. Now, immunoglobulins are rapidly always made, such that if a gene is going to be translocated or transposed on chromosome 14, well, we know that chromosome 14 is always rapidly going to be dividing, i.e. normal function, it's going to be immunoglobulin, immunoglobulin, immunoglobulin. And so if you have a translocation related to chromosome 14 of a certain gene, which we will talk about, you're going to have rapid proliferation of that gene because it is on that chromosome 14. Let's go ahead and go through a test question. A patient was recently diagnosed with HIV. He has been non-compliant with his therapy. He is noted to have headaches. MRI reveals a solitary mass with no calcification in the frontotemporal region. Biopsy reveals a tumor with T cell lineage. Which of the following genomes may be present in this patient's biopsy? A, Bartonella, B, EBV, C, HHV6, or D, CMV? And this is, you're absolutely correct, a solitary mass. Remember, if you have a solitary mass in the brain, you're going to be thinking about three things: primary brain tumor, CNS lymphoma, as well as toxoplasmosis. And this is going to be primarily related to CNS lymphoma and that association with Epstein-Barr virus. All right, so now we're going to be going through some non-Hodgkin lymphoma presentations. Let's go ahead and go through each one. And rapidly enlarging lymph node that is CD20 positive. Well, that's B cell in origin, and you're worried about diffuse large B cell lymphoma. This is one of the most common subtypes of non-Hodgkin's lymphoma. Say that you have an African patient who comes to his primary care physician with a mass on his right jaw that is growing aggressively and that is EBV positive. You're going to be thinking of Burkitt's lymphoma. Now, what is going to be the translocation here? Well, that's going to be the 814 translocation. And as you know, chromosome 8 encodes for c-Myc. So back to that general concept, if c-Myc goes on to 14, well, guess what? c-Myc, 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 cell cycle keeps proliferating and you get a rapidly dividing cancer. Now, typically, when you're talking about Burkitt's lymphoma, you're worried about this starry sky appearance on histology, which represents lymphoid tumor cells with tingible body macrophages. What about this one? A painless node in an adult male? You're going to be thinking about follicular cancer. And follicular cancer has this classic 14-18 translocation. Remember, the immunoglobulin heavy chain on 14 is replaced now by BCL2. Now, BCL2 is a little bit different because this is going to be a gene that is responsible for inhibiting apoptosis. So if you have overexpression or overproliferation of BCL2, going back to our fundamental principles, you're not going to have apoptosis. No apoptosis means that you're going to have cancer. And remember, follicular non-Hodgkin's lymphoma can actually progress to diffuse large B-cell lymphoma. Next one we're going to be talking about is mantle cell lymphoma. Now, mantle cell non-Hodgkin's lymphoma presents as a painless node in an older adult. And if you look at the translocation, it is going to be of a cell cycle, cyclin D, being replaced on that chromosome 14. So cyclin D, 1114. The way I remember this is a mantle is kind of like near your fireplace. And the number 11, I think of 2 candlesticks on a mantle. And so I remember that, 1114 translocation, that's going to be cyclin D and mantle cell lymphoma. Now, remember that if this is going to be the lymph node, you have the follicle, then you have the mantle, and then the last one is going to be marginal zone lymphoma. And a marginal zone lymphoma, you always have to think about, again, somewhat chronic irritation or chronic low-level inflammation. For example, Sjogren syndrome, Hashimoto's, H. pylori. Anytime you have a chronic autoimmune, chronic inflammatory process, you're going to grow the follicle to the mantle zone and the marginal zone. And so sometimes you can see this cancer known as a maltoma. And a maltoma is a subtype of marginal cell lymphoma. And again, all of this is the umbrella term of non-Hodgkin's lymphoma. So key ththings here: Burkitt's lymphoma, 814; follicular carcinoma, 1418; 2 mantle sticks on a fireplace, 1114. That's your mantle zone. And then maltoma, that's part of marginal zone. A patient with Sjogren syndrome has a rapidly enlarging parotid mass. Exam shows a unilateral heterogeneous mass that is not tender to palpation and is obscuring the right mandibular region. Parotid excision is likely to reveal which of the following tumor derivatives. Go ahead and put your answer choice within the chat box. All right, we have people saying D, and if you said D, you're absolutely correct. Remember that the key in this question is that you have Sjogren syndrome, a chronic autoimmune process, and that is going to cause you to have what? Well, you're going to have the follicle, the mantle, and then the margin. And so germinal centers with distorted lymph node architecture is key when you're talking about Sjogren syndrome and the association with a parotid mass or a maltoma. All right. Next portion of this, we're going to be talking about vascular tumors. Vascular tumors are really, really interesting. And again, this is not related to non-Hodgkin's lymphoma, so sorry about that heading right here. Let's go through some important vascular tumors. Angiosarcoma is first. Now, angiosarcoma usually presents as a rapidly enlarging skin mass, or it can actually present as a liver mass in a plumber, for example. And that is because plumbers have exposure, or used to have exposure more to vinyl chloride in those pipes. There's also an association with angiosarcoma of the liver and arsenic. What you have to know is that angiosarcomas are very aggressive. When you're talking about the ones related to the skin, they are going to be in the sun-exposed regions, and there's also an association with radiation therapy. Bacillary angiomatosis is going to be a vascular lesion that presents as a capillary skin papule in an immunocompromised patient. Remember that if you biopsy this, you're going to actually have more of a neutrophilic infiltrate, and we're going to contrast that with our next lesion. Bacillary angiomatosis, high yield for you to know, is associated with Bartonella. So these are vascular skin tumors that we are talking about. The one that we need to contrast bacillary angiomatosis with is Kaposi sarcoma. Kaposi sarcoma presents as an immunocompromised patient, same thing, capillary skin papule or papules with the biopsy revealing a lymphocytic infiltrate. There is an association not with Bartonella here, but HHV8, very high yield for you to know. Now, here are some benign vascular tumors that show up. One is a strawberry hemangioma. That is typically going to be found in infants. It actually is going to be so benign, but interestingly, it grows and then spontaneously regresses. So this is going to be an example of a strawberry hemangioma. Remember, strawberry shortcake, that's a small baby cartoon. So I remember that, that's going to be affecting pediatrics. Now, what's interesting is that on the USMLE, the next best step in management is just reassurance because they grow and then they regress. But if they're on the eye or if they're on areas that are cosmetically very challenging, you can use topical beta blockers. And remember, beta blockers are going to modulate the blood vessels within the hemangioma itself. Lastly, we need to talk about cherry hemangiomas. Cherry hemangiomas are going to be benign capillary growths in middle-aged patients, and you can actually acquire more cherry hemangiomas. Again, they're very benign as you grow older. A patient is diagnosed with a highly vascularized tumor. The vascularized tumor is going to surround normal cellular epithelium. Increased capillary proliferation is seen on microscopic pathology. An increase in which of the following cellular ligands may be expected in this patient? A, EGF, B, FGF, C, PDRF, or D, IGF. And if you said FGF, you're absolutely correct. Remember that VEGF and FGF both are going to increase angiogenesis, and it's fitting that I put them in the vascular tumor section. Remember, EGF, which is answer choice A, is not related to VEGF. EGF has more of a mitogenic influence, which means it grows organs, it grows tissues, etc. All right, everyone. Well, we have a couple more systems left. I encourage you to stay active and engaged. Guys, are you enjoying this review? And are you learning something? Go ahead and put in yes into the answer key. All right, here we go. Soraya, Fatima, Preeti, Miriam, thank you all for joining in. Now we are going to be covering our next section, which is going to be renal cell carcinoma. Now, this is how I broke down actually the whole genitourinary oncology tract. First off, we need to break it down. Remember that on your test questions, if you see bilateral renal cell carcinoma, think of von Hippel-Lindau syndrome. Now, the USMLE presentations for GU cancers, very high yield for you to know, is essentially dependent on you kind of stratifying on the exam whether or not the patient has painless hematuria or painful hematuria. Remember that another presentation of these GU cancers, specifically renal cell carcinoma, is varicoceles. And varicoceles can be present, especially when the renal cell carcinoma actually invades the renal vein. That causes back pressure of the pampiniform plexus. And what is varicocele? It's a dilation of the veins found in the pampiniform plexus. So recurrent varicoceles or bilateral varicoceles, you want to be thinking of renal cell carcinoma that kind of invaded the renal vein. So when you're thinking about renal cell carcinoma, that is that painful hematuria that I wanted you to distinguish. It typically presents with painful hematuria, flank pain, and there's a clear cell variant. There's also some paraneoplastic syndromes, which is basically some systemic molecules the tumor is going to secrete, and we're going to integrate that in the next slide. When you're talking about painless hematuria, you got to be thinking about transitional cell carcinoma of the bladder or of the ureter. But transitional cell carcinoma of the bladder has a strong association with smoking as well as aniline dyes. And I did want to put this very important bladder pathology, and that is hemorrhagic cystitis related to cyclophosphamide. Remember that cyclophosphamide is going to cause free radical injury, and that free radical injury is going to be primarily to the epithelium of the bladder. And you can get hemorrhagic cystitis, which presents as a patient actually peeing out clots. And you want to prevent that hemorrhagic cystitis by giving a free radical scavenger, which is going to be known as a. All right, let's go ahead and go through this question. A patient presents with hematuria and flank pain. He has a fever and hyperglycemia. He has had some weight gain and has also felt fatigued. Exam shows truncal obesity and atrophy of the extremities. So here we are going to be thinking about a paraneoplastic syndrome related to renal cell carcinoma, and that is ectopic ACTH secretion. Now, remember, renal cell carcinoma has not only ACTH, which presents as a Cushing syndrome type of phenotype, but it also is going to have an association with EPO secretion, which typically presents as headache and itching after a long shower. And this is an example of secondary polycythemia. Remember, EPO tells RBCs to keep proliferating, and the itching is due to the histamine response that you are going to get with increased cellular burden. You also want to integrate renin as a paraneoplastic syndrome related to renal cell carcinoma. Now, how does ectopic renin secretion present? Well, similar to hyperaldosteronism, hypertension, and hypokalemia. And then finally, you're going to be thinking about PTHRP, and PTHRP is going to be associated with renal cell carcinoma as well as squamous cell carcinoma of the lung. And this is going to be parathyroid related peptide. So it's going to present as hypercalcemia. Maybe they put in the test question recurrent kidney stones to kind of clue you in on hypercalcemia. So what is the most common histopathological presentation of renal cell carcinoma? We went through this. Remember, this is the clear cell type, which is described as polygonal cells with high glycogen content. And you can see that right here. You see this glomerula right here as well. Where in the nephrons are these clear cells arising from? This is interesting, the proximal tubule. And the reason why I bring that up is renal cell carcinoma is different than another high yield renal cancer, and that is the renal oncocytoma. And renal oncocytoma actually arises from the collecting ducts, and it's a benign tumor that has, on histopathological findings, large eosinophilic cells with increased mitochondria. And this is the gross pathology of a renal oncocytoma. The next topic we're going to be talking about is going to be Wilms tumor. All right, so Wilms tumor, let's go through this test question. A mother brings her son in due to abdominal distension. Her mother states that her son has been having normal bowel movement, so it's not constipation. She noticed while bathing him last night that he had increased abdominal fullness more on the left side. CT scan reveals a homogeneous mass at the inferior pole of the kidney that does not cross the midline. Very high yield for you to know that. If this oncological lesion was associated with a genetic syndrome, which of the following additional findings may be present? A, episcleritis, B, aniridia, C, uveitis, D, glaucoma. What do you all think is the answer here? So the mass which I'm describing here is going to be a Wilms tumor, also known as a nephroblastoma. It is a common tumor in pediatrics. It is going to actually not cross the midline. That differentiates it from a neuroblastoma. Neuroblastoma crosses the midline. Nephroblastomas are unilateral, and they are associated with the WAGR, also known as the WAGR sequence. And we're going to be talking about that soon. And the A in WAGR actually stands for aniridia. So nephroblastoma, let's go ahead and go through this question. A 15-month-old male brought in by her mother after she noticed decreased appetite and a mass was felt while bathing him. Do you see this pattern? He is evaluated and actually found to be hypertensive. What is going to be the pathologic hallmark of this diagnosis? And that is actually going to be blastema. Now, blastema is going to be one of the histological findings that you see in Wilms tumor. And a blastema represents a primitive cell which makes glomerulus and tubules. And obviously, that is going to have some oncological changes when we talk about Wilms tumor. The genetic hallmark of Wilms tumor is this loss of WT1, which is a tumor suppressor. And if they put a 2-month-old who presents with hepatosplenomegaly, tongue hypertrophy, exam showing increased bulk on the left side compared to the right, i.e. hemihypertrophy, along with this association with Wilms tumor, you're going to be thinking of this interesting syndrome known as Beckwith-Wiedemann syndrome. And Beckwith-Wiedemann syndrome has an association with Wilms tumor, and it has this characteristic hemihypertrophy, whereas one side is going to be larger than the other. Now, we also talked about another syndrome that is associated with Wilms tumor, and that is the WAGR syndrome, and that has Wilms tumor, aniridia, GU malformations, and intellectual disability. This is going to be a picture that is a histological finding of Wilms tumor. You see the blastema, the tubules, as well as the mesenchyme. And all of these are undergoing neoplastic changes, and that's what's giving you the nephroblastoma. So I do want to integrate renal embryology here. What I want to really drive home the point with is the association with the metanephros, which is a primitive renal structure, and the ureteric bud. Remember that the metanephros actually gives rise to everything from the glomerulus to the distal convoluted tubule. So I'll put a line right here that differentiates it. Everything else is going to be ureteric bud, collecting duct all the way to the renal pelvis and ureter. So what's important is that in renal embryology, you are going to have this interaction between the ureteric bud and the metanephros and the underlying mesenchyme. And it's kind of like an electric plug in a socket. And you want to make sure that the interaction is going to be normal, because then you can get normal glomerular structures. However, if it is abnormal, you end up getting to some pathologies, and let's cover that. So what pathologies are related to an abnormal interaction between the ureteric bud and the metanephros? Well, one is known as unilateral renal agenesis, and that is the failure of the ureteric bud to even form. So you're not going to have any kidney or ureter. And guys, I'm here to be so integrative with you. What can that lead to? Well, that can lead to oligohydramnios in utero because you can't circulate the amniotic fluid. You also have a pathology known as multicystic dysplastic kidney. And that is the failure of the ureteric bud to actually induce the mesenchyme. And thus, you don't have good ureteric bud and metanephros interaction. And this classically presents as a unilateral, non-functional cystic kidney. And so I wanted to give you this embryology tie-in because it frequently shows up on exams. All right, guys, we only have a couple more systems left. So stay active and engaged. We have lung cancer, we have brain tumors, we have breast cancer, and then we're done. So our final 3 cancers. Let's go ahead and go through a quick test-taking strategy as to how I approach lung tumors. Typically, USMLE questions are going to have these constitutional symptoms, and yet again, we see paraneoplastic syndromes associated with lung tumors. If this is going to be your lung epithelium, remember, it's classically described as a pseudo-stratified columnar epithelium with cilia and goblet cells. You do want to integrate some specific cancers related to the lung epithelium. Adenocarcinoma, which again comes from more glandular epithelium, and small cell carcinoma, which actually has a neuroendocrine type of tie-in. Remember that there is an association with cancer. And there's an association not only with cancer, but with smoking. And remember, smoking is actually going to cause you to have some element of metaplasia, where this columnar epithelium ends up turning into more of a stratified squamous epithelium. And that metaplasia throughout time can lead to dysplasia and subsequent squamous cell carcinoma. So as you can see, this is an irritant that ends up being a cellular stress. You switch your tissue from columnar to squamous, and you can undergo then the metaplasia, dysplasia, carcinoma sequence. All right, so talking about lung cancer for the USMLE, let's go through some high yields. The risk factors you're going to see, especially for the cancer that start with smoking, hemoptysis that can mimic TB, and then you always want to integrate the pneumoconioses, and those are those environmental exposures. And I have a whole video on my course that actually goes through the pneumoconioses. The USMLE presentation can be that of paraneoplastic syndromes, or they may say, oh, you have a lung mass on chest X-ray or CT. I want to integrate a very high yield lung cancer, and that is these Pancoast tumors, also known as superior sulcus tumors. Now, these are going to mess with your preload, i.e., they're going to cause compression of the SVC. And so you can get an SVC syndrome with these superior sulcus tumors. These tumors present then with facial plethora because of lack of venous drainage, headache because everything kind of gets backed up into your CNS, right upper extremity edema because that's where the actual SVC is, as well as Horner syndrome because you disrupt the sympathetics. So now what we'll do is we'll quickly go through a rapid fire of all of these tumors. Remember that squamous cell carcinoma and small cell carcinoma have the associations with smoking. Adenocarcinoma typically is going to have on histology prominent glands and mucin. It's going to be a cancer in non-smokers and females. It is going to be peripheral in etiology, and it can present as a pneumonia-like consolidation. And there is this association with Clara cells, which are one of the normal cells that you see within the epithelium of the lung. Small cell carcinoma, I want you to pay attention to the paraneoplastic syndromes. Remember that small cell carcinoma have that neural type of association. And that's why you're going to have neural stains that are going to be positive. So chromogramin, you're going to have these Kulczycki cells that are having a neuroendocrine derivative. And this is a small blue cell tumor. And because it's a small round blue cell tumor, remember that it's going to be very hard to resect these tumors. And you're going to primarily use radiation and chemotherapy as your mainstays for treatment. The classic patient is going to be a smoker. There's rapid growth and early metastases with these tumors. Because it has the S sound, it's going to have a central nature in terms of presentation in the lung. And remember that the paraneoplastic syndromes associated with small cell are SIADH, which presents as hyponatremia, ACTH, Cushing syndrome, Lambert-Eaton syndrome, which is an antibody reaction to the voltage-gated calcium channels that presents as weakness and a lung tumor. And remember that this weakness gets better with repetitive stimulation. And remember that for small cell, we don't use resection, we use more radiotherapy. Wrapping up here, squamous cell carcinomas. Squamous cell carcinomas have squamous derivatives, and that is your intracellular bridges and the keratin pearls. Remember that this is going to represent those desmosomal connections. There is high level of cavitation and necrosis on gross pathology. It's associated with smoking and a central distribution. And remember that squamous calcium, i.e., you're going to have this association with PTHRP. All right, guys, last two sections, brain tumors, breast cancer, and then we are done. Are you guys staying active and engaged? Go ahead and type in yes into the chat box. Thank you so much for the encouragement. Your energy drives my energy, and I hope that you guys are staying super active and engaged. Let's go ahead and go through brain tumors, breast cancer, and then we'll synthesize everything together. Thanks for tuning in. Here we go. Neuro-Oncology for the USMLE. Key things for you guys to know are that there are genetic associations that could be related to brain cancer. And these are risk factors in your exam question. Things like Turcot syndrome, which presented with colonic polyps. We talked about that. Neurofibromatosis. Von Hippel-Lindau, which is associated with cerebellar hemangioblastomas. Retinoblastoma, even tuberous sclerosis. All of these are going to have are going to be risk factors to brain tumors. Now, the USMLE presentation for brain tumors can be very variable. However, you do want to recognize headache and signs of increased intracranial pressure. And remember that if you have severe intracranial pressure increases, you could get the Cushing's triad, which is going to be hypertension, bradycardia, and irregular respirations. Now, because this is affecting the brain, you can have also stroke-like symptoms, and you can have seizures because it's going to mess with the neuronal firing. what we need to know is that the most common oncological lesion to the brain is going to be metastasis. High yield for you to know. And what we need to recognize here is that metastasis usually occurs at the gray-white junction. And here are the list of cancers that are going to metastasize to the brain. And how do I recognize metastasis? Again, multifocal lesions on your CT scan of the brain. Now, I do want to also go through some normal histology. Remember that astrocytes are going to be cells that support the blood-brain barrier. Oligodendrocytes are found in the brain, and they are going to myelinate the CNS. Remember, Schwann cells myelinate the peripheral nervous system. Microglial cells are macrophages of the CNS, and then ependymal cells are going to make the CSF, and that's going to circulate in your ventricles. You can also use age as a general clue in on your brain tumor questions. Remember that adult tumors are going to be related to metastasis, glioblastoma multiforme, meningioma, and schwannomas. And those are going to be supratentorial. Infratentorial tumors are more childhood tumors. And those are going to be astrocytomas, medulloblastomas, and ependymomas. So I remember in terms of Disney parks, I remember Animal Kingdom, Magic Kingdom, and Epcot as my mnemonic for the childhood brain tumors. So let's go through a rapid review. A male who dies after having a rapidly expanding brain tumor crossing the corpus callosum, you're going to be thinking about glioblastoma here. And remember, that's a high-grade astrocytoma that's GFAP positive, has high EGFR, and it is going to have pseudopalisading tumor cells on your histology. What about a female with seizures and an exophytic brain lesion that arises from the dura mater? This is going to be a meningioma. Again, it's arising from the meninges. And so meningiomas are going to have Samoma bodies. Remember, those were the two M&Ms with the Samoma bodies. And they are going to have, because it's a Samoma body, that world pattern and calcifications. And remember, meningiomas also can be ER positive. Watch for the seizures. That always is in test questions, seizures and a brain mass. What about if you had a family history of CNS tumors, hearing loss, tinnitus, and a tumor found at the cerebellar pontine angle? Here, you're going to be thinking about the NF2 association and schwannomas. Remember, just like melanomas, they have a neural crest type of derivative, and that's going to be S100 positive in association with NF2, and it's commonly going to involve cranial nerve 8, though it can involve many of the cranial nerves, but schwannomas classically involve cranial nerve number 8, vestibulocochlear nerve, and they arise in the internal acoustic meatus of the skull. Now let's go into some pediatric brain tumors. What about a posterior fossa tumor in a child and the biopsy reveals hair-like projection, you're going to be thinking of a pilocytic astrocytoma. That one is going to be GFAP positive, and that makes sense because glioblastomas were high-grade astrocytomas. Pilocytic astrocytomas are going to be low-grade GFAP positive tumors. You get these eosinophilic corkscrew fibers known as Rosenthal fibers associated with astrocytomas. And astrocytomas very characteristically have both cystic and solid components on gross pathology. And that's different than something like a medulloblastoma. So medulloblastomas present as a malignant brain tumor. It's in the posterior fossa. So you can have spinal cord metastasis, and that can present as truncal ataxia, along with the fact that it's near the cerebellum. Remember that medulloblastomas are PNET positive. These are aggressive tumors that are small blue cell inderivative and are going to have synaptophysin, which is a neural endocrine marker, synaptophysin positivity. Let's wrap it up. Bilateral ventriculomegaly plus obstructive non-communicating hydrocephalus. This is when your ventricles, are growing. Well, this is a fourth ventricular mass known as an ependymoma. And ependymomas have a fourth ventricular mass that essentially obstructs your CSF circulation. And that is what's going to contribute to the ventriculomegaly. And on histology, you get these perivascular pseudo rosettes, which are different than in medulloblastoma. You get the Homer Wright rosettes with medulloblastoma. All right. Our last section of the day. Stay tuned, stay active, stay engaged. This is going to be breast cancer. Now, the risk factors for breast cancer, I always think of high estrogen states. There's also genetic, but I always just say high estrogen states. So that tells me, postmenopausal female, if you have late menopause, maybe that can cause you to have an increased risk for breast cancer. Obesity, there's an association. Atypical hyperplasia, obviously you can progress to carcinoma then. A first degree relative, that's where you're going to be thinking about BRCA mutations. Remember, BRCA mutations are going to be associated with invasive lobular carcinoma, but you can also get serous ovarian cancers associated with BRCA. And you're going to be thinking of nulliparity as one of the risk factors for breast cancer. So these are all going to be interspersed throughout your vignette. Let's go ahead and go through this question. A 60-year-old female presents concerned about a right breast mass, which she felt in the shower. She notes there is associated dimpling. There is no redness or fluctuance to the breast. There is no family history of breast cancer. There is prominent lymphadenopathy in the right upper quadrant of the breast. She is found to have an irregular, immobile mass on palpation. Which of the following affected structures may be most contributing to her nipple dimpling? A, axillary lymph node involvement, B, suspensory ligament involvement, C, lactiferous ducts involvement, or D, mammary artery? And remember, this is a specific question from the vignette. And if you said B, suspensory ligament, that is exactly what's causing the dimpling, which this question is going for. All right, so here is a summary of breast cancer. What I want you all to recognize is that here's the breast, and if you zoom in on the breast, this is known as the terminal duct lobular unit, okay? Terminal duct lobular unit. Here's the duct, here's the lobules. That's normal. Now, cancer can arise from the normal. One of the cancers is confined to the basement membrane, and that's where you have nuclear atypia. And if it's confined to the basement membrane, it's known as ductal carcinoma in situ. Now, there's a comedo type that has a lot of central necrosis, a lot of nuclear atypia, and that frequently is the most common DCIS subtype. Now, what's important for us to recognize is that if ductal carcinoma in situ actually goes up towards the skin, you can get an eczematous patch of skin right on the breast itself. And that is related to Paget's disease of the nipple. So Paget's disease of the nipple just represents very high yield ductal carcinoma in situ that went up towards the skin of the breast. If the actual tumor cells of the breast in the duct end up actually invading the basement membrane, you get vascular and lymphatic infiltration. And remember, the lymphatic drainage is going to be of the axillary lymph nodes. That's why we do the sentinel node biopsy. And that's where we get invasive ductal carcinoma. And that's the most common type of breast cancer. Now let's transition our talk to lobular carcinoma. Remember, the lobules are here, and that can produce cancer. Obviously, if it's confined to the basement membrane, it's known as lobular carcinoma in situ. And if it breaks the basement membrane, it's known as invasive lobular carcinoma. Now, what I want you all to recognize here is that when you see lobular, say the word line, i.e. tumor cells are going to be in a line. And that is due to very high yield, a loss of E-cadherin. E-cadherin actually is going to connect cells together. So when you lose cadherin, you end up getting cells that are going to be spread apart, and they're going to have a mind of their own, and they're going to travel in a line and metastasize. The last skin lesion that I want you to recognize here related to the breast is going to be peau d'orange, which is going to be representative of inflammatory breast cancer. This is going to be a thickened patch of skin, and it's going to be red and hot. You're going to also have a differential of mastitis or breast abscess. But in the case of mastitis, it typically responds to antibiotics. Inflammatory breast cancer, does not. And so that's how you can stratify that red hot lesion on the breast. A patient presents with unilateral breast redness. She is 3 weeks postpartum and had a breast mass, which was being worked up prior to pregnancy. She has completed a course of decloxacillin with no relief of her breast redness. She is currently not breastfeeding. Ultrasound of the breast shows no abscess. There are hard lymph nodes in the axilla. Which of the following pathophysiologic mechanisms may be contributing to the underlying pathology? A, lymphatic duct obstruction. B, fibrotic suspensory ligament of the breast. C, infection of the superficial epidermis by methicillin-sensitive Staph aureus. Or D, DVT of the left brachial vein. And this is the presentation of peau d'orange inflammatory breast cancer, and the skin lesions are due to lymphatic duct obstruction by malignant tumor cells. So one thing that I have to bring up is breast cancer and its relation to 3 specific stains. Questions typically refer to these 3 stains: ER, which is estrogen, PR, progesterone receptor, and HER2/neu, which is a gene amplification product of the tyrosine kinase receptor. Now, they love to test the pharmacology association with these 3 stains. A patient is found to have both ER and PR positive breast cancer. What is the characteristic of the receptor this cancer expresses? And remember, because estrogen and progesterone are steroid hormones, they are going to be nonpolar, i.e. lipid soluble, and they are going to actually cross the lipid bilayer. And that's why these hormones have an intranuclear or intracellular domain. Very high yield for you to know. And that's why if you integrate the drug tamoxifen actually works intranuclearly. Because why? The target is the estrogen receptor, and the estrogen receptor is, guess what? Within the actual cell itself, because it's a steroid hormone. Those hormones cross the lipid bilayer. This is just a plug that if you are struggling with pharmacology, ladies and gentlemen, please check out my rapid review pharmacology course, 6.5 hours, single speed, highest yield, pharmacological agents explained in a pathophysiologic manner. I highly recommend you check it out, HyGuru.com. All right, last question. A patient is started on chemotherapy treatment for an immunohistochemical staining positive breast cancer. She is found after getting started on the chemotherapy to have an echo with low ejection fraction. What is the likely mechanism of the chemotherapeutic treatment? And this is going to be inhibition of HER2/neu. Ladies and gentlemen, it is not enough. It is not as efficient to make random Anki cards that say trastuzumab cardiotoxicity. You need to understand the application. And that is that, cardiotoxicity for doxorubicin, for trastuzumab, that presents as low ejection fraction, right? Low ejection fraction. So this is a chemotherapy-induced cardiomyopathy. Very high yield for you to know. And remember, trastuzumab is a HER2/neu inhibitor. This is the summary that we are going to be going through today. All right. We covered a lot of great organ systems. Let me go back to the basics. Here we go. When you're talking about cancers, we frequently get tested on the difference between grading and staging. So what are those vocab words? Well, grading is going to represent how does that cancer look compared to the normal tissue, i.e. grading comments on the degree of differentiation, the nuclear features, the invasiveness of the cancer. Grading asks the question, does my tumor or do the cancer cells look like normal tissue? If the answer is no, this cancer looks way different than normal tissue, then it's known as a high-grade lesion. Staging is a little bit more important because staging has this classification of TNM, which stands for tumor, nodal involvement, and metastasis. So obviously, you're going to have a high stage cancer, if you have large tumor size, if you have nodal metastasis, and if you have metastasis to various portions of the body. What are the 3 areas in the body that have the most metastasis to them? Bone, lung, and liver. Those are the 3 things. And if you're preparing with me for step 2 CK, remember that as soon as a cancer is diagnosed, the next best step in management is get a CT scan of the abdomen, chest, pelvis, etc., because you want to understand the TNM classification. If you have metastasis to these organs, you're going to have a most likely poor prognosis. And that tells you that you have a high stage cancer. So metastasis, we said bone, brain, liver. Let's go through this. Colon, stomach, pancreas cancer. It makes sense by the portal drainage that you are going to have metastasis to the liver. What goes to the brain? Lung, breast, and melanoma. Very high yield for you to know those. And lastly, to the bone, you're going to be thinking about prostate cancer, which presents as back pain in a relatively elderly patient, breast cancer, thyroid cancer, and lung cancer. Because again, these start here and they move posterior. High yield for us to know that prostate cancer is going to have blastic lesions along with breast cancer, and then thyroid and lung, there are going to be more lytic lesions on your bone scan. Ladies and gentlemen, thank you so much for attending today. Give me 5 more minutes of your time. When we think about oncology, a couple things. Metastasis usually presents as multifocal lesions on gross pathology or imaging. Point number 2, recognize constitutional symptoms. Remember, anorexia, weight loss, fatigue, that all represents that your body, just to tie in some biochemistry, is in a catabolic state. And the principle of neoplasia and all of these cancers we talked about is essentially either too many cells are proliferating, cell cycle is going cray, or there's a lack of cells dying, i.e. there's a lack of apoptosis. How many of you all loved the active recall and integration? Go ahead and put yes into the chat if you loved all of the high yield questions in this review today. Awesome. Well, many of you have reached out to me regarding one-on-one preparation, and I am absolutely humbled. But for those of you who private tutoring may not be something that is right for you, I want to kind of bring in a resource that gives you a one-on-one tutoring experience right in the comfort of your study space. And that is my test taking strategy and rapid review course. Now, this course is going to be intended for those students who are having a little bit of issues with applying the content to NBMEs and UWorld questions. I give you a structured approach on how to actually attack and apply the information. It is also intended for students who are wanting to get a boost in their NBME practice scores, or if you're 3 to 4 weeks out from your exam, you want a comprehensive review that goes through general pathology, ethics, autonomic pharmacology, even the rapid review of first aid in an organ systems-based manner. I highly recommend you check this out. So many students have already utilized this course, and guess what? It is a very short course, about 12 hours of information in single speed, but it is so valuable for your preparation. Finally, I do want to let you know that I have a pharmacology course, which basically puts together sketchy concepts and pathoma, but I teach it more in a pathophysiology and pharmacology integration style. Remember that pharmacology is about 20%, and they are easy points. So definitely check out this course. And if you're interested in all of my resources on my website, HyGuru.com, I actually even have a bundle course. And a bundle course basically has all of my resources put together. And guess what? You get a one-on-one tutoring session with me as part of the bundle course. And I just put that in the chat box. But if you are interested in the bundle course, please check out my website. And again, it comes with a one-on-one session with me where we go through the areas that you're having trouble with. I advise you so that you are less stressed for your exam and your preparation. I want to thank each and every one of you for being here. Truly, it is so humbling to have so many people from all around the world just tuning in for this review. I hope you learned a lot. and blow up HyGuru, my passion project. Please blow it up on Reddit, on Facebook, on YouTube. Tell all of your friends. I'm trying to grow this from the ground up. I'm so passionate about helping you all because I realize how stressful this exam is. And if I can have a unique, innovative way on making an impact on your score, man, that is what makes the world spin. So tag me in all of your stories. And before you leave, guys, type in one thing you learned into the chat box today. And at this point, I'll also answer any questions you have as well. But before you leave, one thing you learned in the chat box.